I think it's 9:01, 9:02 actually, we just flipped it. So I think we can go ahead and get started. Welcome everyone. Thank you so much for being here. Welcome to the people online. I'm Kate Rankin. I'm the Managing Director of WACh, and we are very, very, very happy to welcome Dr. Linda Eckert today to speak about her new book, which is entitled Enough Because We Can Stop Cervical Cancer. Dr. Eckert is a professor in the Department of Obstetrics and Gynecology and adjunct professor in our Department of Global Health. Dr. Eckert is also the Associate Director for Obstetrics and Gynecology within WACh, which is the Global Center for the Integrated Health of Women, Adolescents, and Children. So we're so happy to welcome you today. Thank you for being here. And with that, I will hand it over to you.
And thank you all and people online too. And it's such a wet, pouring day in Seattle that people who braved getting out. I really appreciate it, and it's an honor to be here. It was so fun to look forward to this because it's like your global health peeps, and all of us sharing a passion for what we do, which was also the passion behind the book. So I guess to start out talking about the book, I wanted to start with a story that I prepared for Moth about why I wrote the book. How many people are familiar with the Moth Story Hour? So Moth is a nonprofit organization based in New York that centers the power of story to change lives. That's their logo. It's been around for about 20 years. I listen to it all the time when I'm driving. They have podcasts, they have radio broadcasts, and the stories are typically 5 to 10 minutes. They have to have a kind of an epiphany moment, and they're always eye-based. And I was really fortunate about a month ago that I applied for this Gates-funded opportunity to learn about Moth storytelling, and it was a workshop held in Nairobi. And they were funding spots for people to raise cervical cancer advocacy. And because my book that I'm talking about is full of stories of individuals, I thought this is just a great opportunity. And so I applied, and I was ecstatic that I got in. I was the only North American that got to go. And it was a really monumentally awesome experience. But what surprised me, and I should have thought of it ahead of time, but the stories that they want you to create are eye-based, and my book is other-based. You will find me in the book as I go through and talk about it, but it's not really my book. It's a book about all these people who have cervical cancer. And so I was a little bit challenged to figure out how I was going to talk about this. And my instructor just said, just tell us why you wrote this book, who you are and why you wrote this book. And then you can talk about the book. So that's kind of the approach I'm going to take. So I started the Moth story when I was in medical school. I was 25 years old, and I was a few months away from graduation. And I had always wanted to be a doctor since the age of 4. I was one of those science nerds. I loved dissecting things, cutting things up, and was that person in the class. And then when I was in high school, I also decided that I wanted to be a doctor and work overseas. I grew up in Wyoming. I was really curious about other cultures. But I also just felt this burning need to try to use the great education and the opportunities I had to serve people who didn't have access to medical care. Kind of the mantra of those to whom much is given, much is expected. And then when I was in medical school, I worked for 2 years to get the necessary permissions so that I could get clinical credit for an overseas rotation. And so at the end of my 4th year of medical school, just armed with my brand new passport, I flew across the Atlantic for the first time with all my idealistic 4th year medical student heart and landed in rural Liberia, where I worked in a hospital and clinic for 4 months. And I was going to finish up my medical school education with this last 4-month rotation there. And so I was 2 days into my rotation when my mentor, Dr. Steve Beefus, approached me and he said, hey, I have a patient I want you to see with me, whom he respectfully called Mama. And Mama had been brought to the clinic by her son because she had intractable back pain. And I walked into Mama's room with Dr. Beefus, and what struck me right away was the odor. It was just pungent, hanging in the air, so putrid that embarrassingly, I actually gagged. And I would come to learn that that was the smell of advanced cervical cancer. And I would also come to learn that Liberia had no screening for cervical cancer, certainly no treatment for mama or individuals like her, or in many countries the same way. And so my idealistic medical student heart was just slammed against the reality of the global inequity of cervical cancer. And I remember Dr. Beefus talking to me and saying, "You will never forget this patient." And he was right. I carried mama with me in my heart as I came back to the US and I finished my training. And as I went on in my training and my practice, I actually found mamas everywhere, all over the United States, Central America, South America, Kenya, anywhere I worked. And while my colleagues who were in residency went on to take jobs in the US, great jobs, great colleagues, I just found this burning passion in me still that I felt like I needed to try to address this global inequity of a preventable cancer that was killing woman after woman, and it was preventable. And how could we somehow address this? And so I decided that that would need to be one of my career focuses. Well, we had a really happy moment in 2006. The HPV vaccine came on board. And I thought, oh, this is so great. We can prevent this cancer. But I just kind of watched in anguish in this country as it languished on the shelf because people wouldn't use it, or globally because there wasn't enough money or enough supply. And cervical cancer cases just kept rising. And then I thought, oh, I'll work on guidelines. And I was really fortunate. I got to work with the World Health Organization on cervical cancer prevention guidelines. I got to travel to Namibia, to Malawi to work on guidelines. All of this was great work. But again, I watched as guidelines stayed on the shelf because both guidelines and vaccines need political will and money. And those always seem to be in short supply. And so then in 2018, it was a great moment again. The WHO had announced for the global launch of the Cervical Cancer Initiative. And I remember sitting around this table in Geneva. There were about 50 of us, all with our name tags in front, looking at each other, trying to figure out how we were going to come up with this strategy for the elimination of cervical cancer. And we were all so excited to be there. But I had this kind of disconnect. And I thought, we've made guidelines before. What can we do? And then I looked around the room and I thought, where are the women? Where are the stories of the women with cervical cancer? Because we all know the power of story to change, to motivate program managers, to motivate finance ministers, to try to really make a difference in grassroots organization. We need more stories of women with cervical cancer. And that night, I was in my hotel and I was writing my journal, just kind of debriefing about all that was swirling around me. And I wrote the word enough. I wrote the word, I have seen enough. And then I thought about it and I thought, I actually have enough. And then this crazy idea came to me. I thought, I have to write a book. I have to write a book that collects stories of women from around the world, from all walks of life, with cervical cancer, and try to present it in a relatable way so that people can personalize it and realizing this isn't a disease over there or over there. This is a disease that I could get, or my sister could get, or everyone could get. This is a really relatable problem, and this is a preventable cancer. And I need to try to talk about this cancer in words that people can understand and take on board. And so now, 5 years later, I have this book, and it's called Enough. Enough because we can stop cervical cancer. And the bedrock of this book is the stories of women with cervical cancer from around the world. So that was my mom's story. And thank you for listening. And so as I talk about the book, I'll read just a little bit, and I kind of just wanted to show you the contents and answer questions, talk about some of the people that helped me so much in the book, but mostly just have a discussion for wherever people want to go, and answer questions, so forth. So it's really open here and also online. So the book, as I mentioned, is centered in stories. And there's 17 chapters, and each chapter hits a major theme. But each chapter has at least one story, either from my own personal experience caring for women or from stories that people gave to me. And I was collecting the stories in 2020, and I was planning to travel to places and work with people like my colleague Nellie Mugo and others to get stories for cervical cancer. But of course, COVID hit. So I ended up collecting most of the stories over Zoom or drawing from my own personal experience. And so that's how I got this particular story. And this particular story is part of the chapter that's called The Deadly Link Between Inequality and Cervical Cancer. In 2011, Kim, an American working mother of 8 children, started making regular trips to Haiti as part of a volunteer church group based in Cincinnati, Ohio. And it was during one of these trips that Kim met Elvia. Their cross-cultural friendship would span their differences. It would carry life-affirming as well as life-altering implications. When the two women met, Elvia was working as a street vendor to help support her 2 young children. She sold drinks and snacks in front of her house in Port-au-Prince, the town where Kim's volunteer group taught technical skills to Haitian children. Elvia and Kim's children often played together, roaming effortlessly between the 2 households, and Kim and Elvia grew just as comfortable with each other. During Kim's visits back and forth from the US, the 2 friends remained in close contact. On one of those ordinary days when Kim and Elvia were enjoying time together, a neighbor offered to snap a photo of Kim and Elvia and Elvia's children just outside their neighbor's home. And that photo is in the book. Kim now finds it chilling to look at that photograph she keeps nearby. Because on that very day, both of them unknowingly had cervical tumors growing inside of them. And while Kim and Elvia shared the same type of cancer, they were instantly separated by the vast differences in accessing cervical cancer treatment. When she returned from Haiti, Kim was determined to see a doctor for her routine pelvic exam. She put it off for 7 years, allowing her busy life to get in the way. Finally, she told me, I listened to that voice inside me and I made myself get my pap smear. And a few days later, the test detected abnormal cells, a biopsy revealed stage 1B cancer of the cervix, and just as quickly, Kim was referred to an oncologist. In just a few dizzying days, she told me, I started chemotherapy and external beam radiation, followed by brachytherapy. During her initial treatment, Kim continued to work, but 3 months later, she developed a serious infection in her damaged uterus and needed a hysterectomy. The emotional and surgical ordeal finally hit. I was so exhausted, Kim said to me during our September 2020 chat. So exhausted that I was off work for several months to recover. She found herself with debilitating radiation enteritis, and that also made it hard for her to work. She said it was so awful. I had to always carry extra clothes in my car because I never knew when I would soil myself. And this challenging treatment side effect for Kim would continue for 3 years. But while Kim was undergoing cancer treatment in the United States, in Haiti, Elvia started to experience visible symptoms of cervical cancer, including leg swelling and back pain. Elvia had never had a pap smear because in Haiti, pap smears would cost as much as a month's wage. And screenings for cervical cancer is typically infrequent or non-existent for women there, as it is in many lower-income countries. And although her treatment was grueling, Kim was grateful for it. She was mortified by the lack of treatment available for her good friend Elvia. They told her she had a tumor and there was nothing they could do for her, Kim recalled. At that time, Haiti had no radiation machines in the country, nor did Elvia have any options to access treatment elsewhere. Indeed, in all of Haiti, no radiation machines are available to provide radiation for cervical treatment. The next closest country happens to be the United States. Kim told me in Haiti, the rich leave the country to get treatment. The poor have come to expect they will not receive treatment. And the middle income, well, They may try to raise the money to get themselves treated, but their options are very inconsistent. And without that treatment, of course, most Haitian women struck with cervical cancer will die painfully and quickly. Kim's experience with this form of inequity became deeply personal. Because Elvia couldn't afford to leave the country for expensive radiation treatment, she died a few months after her diagnosis. I never saw Elvia again after that visit when this photo was taken, Kim said, her voice laden with sadness. And alongside her grief, Kim was outraged over the injustices her Haitian friend suffered. I keep that photo of me and Elvia next to my bed, she told me as she gazed from the screen, lost in thought. No matter how painful the brachytherapy was, or how terrible I felt, or how bad the diarrhea was, my kids are going to grow up with my parenting them. I cannot complain. I'm alive. I'm alive because I did not live in Haiti. I'm alive because I live in a country where I could get treated for cervical cancer. My children still have a mother who is living. When Kim finally looked at me again, tears rolling down her face, she said, for no other reason than when we were born, Elvia died and I lived. And I think of that every night when I look at our photo. Elvia's kids were 10 and 11 when she died. Well, as you can see, these stories are still very raw and personal to me. And so I think that's kind of a flavor of how story is used. And then this chapter goes on to talk about kind of the inequities in access to treatment and screening. Sorry about that. Well, I'm not really sorry. It's quite a book, but and writing it was quite a journey. So I just prepared a couple of slides to just talk about kind of the topics that the book hits, and then I'll be done talking. I'll be happy to take questions. First slide. So I love the copy. This was designed by, this was designed by a woman in Australia, and it looks kind of Aboriginal to me. So Cambridge did this. I had nothing to do with the cover design. And I was also really happy that Nicholas Kristof, whose book about girls and women and their health, Half the Sky, was one of my initial pushes for the passion of global health and equity in health. And he covered maternal mortality, female circumcision, and child prostitution in his book, again through story, where he went around the world and interviewed people, and then he used that story to kind of capture you and present information. Now he's a New York Times person with a Pulitzer Prize winner with a whole machine behind him. And I was not that person, but I was really happy that I was able to get a hold of him, and he has endorsed the book. And so he's on the front cover. And so that was really exciting for me, since the book he wrote with his wife has been one of my main global health inspirations. And if you haven't read Half the Sky, it's definitely worth the read. So this book it has four basic parts. The first part, the calling, is an introduction where I just talk about kind of who I am and why I wrote this book. It has a story of a woman from Nicaragua. The second part, or part one, talks about the cancer itself. And really lays out the case for the global problem that it is, ending with this kind of pinnacle chapter about asking what is the worth of a woman, and if a woman is not worth enough to save her life. The part two talks about the science behind the cancer. It talks about HPV, talks about how we can prevent it, how we can treat it, and then it addresses the HIV, HPV kind of dual pandemics and why HIV modulates HPV so much. And again, these all have stories in them. Part three talks about the prevention problem. Chapter 8 deals with inequity. That's what this chapter reading was from. Chapter 9 starts on the HPV vaccine, talking about losing the life lottery because of where you were born, talking about access and global market shaping of the HPV vaccine, some of the challenges we've had with price. And the next slide, please. And then the next chapter is about obstacles to screening, then talking about treatment. And last, chapter 13 is also kind of, I would say, a pinnacle chapter. It talks about what money cannot buy, addressing patriarchy and stigma, and how they impact cervical cancer and access to treatment. And that, again, has this killer story that I just could never have made up. And then part 4 talks about really what we can do and where we're going to get. And it leads off with this sea change starts with a ripple, which is a wonderful story from Karen down in the far right, who is in Zambia with cervical cancer and has become a big advocate, and now has a Facebook page, Teal Sisters, that has 135,000 followers and has become a global speaker for cervical cancer. It talks about the role of men in HPV and how they can be involved. Chapter 16 talks about how you actually can get involved and it's pretty tangible with options for everyday people. You don't have to write a book. You don't have to start a 150,000 person Facebook page. What can everybody do? And it ties in with a lot of people's stories that are featured here, but also with a resources section that's at the end of the book, so that if people feel called that they want to get involved in this, there's different global options and local suggestions. And then it ends with the calling revisited. And so what I thought I'd do is just in this part where I just show you the faces of some of the women in the book. And what I really love that Cambridge did is that they are putting all of these pictures in color, and they're either in the chapter or they're on the end papers that line the book. And we're also getting a banner made so that whenever I talk about the book, I can have the faces with me, since the book is really their book and it's about them. So yeah, this is some of the faces. And
where are the other women, Lindy?
so go back. So this woman on the far left, her name is Cassie. She has 2 children. She was diagnosed when she was pregnant. She lives in Toronto. This is Eckert, who is on the bottom. She's in Hungary. And she started a grassroots organization in Hungary called Mallow Flower for cervical cancer advocacy. And she's been really involved with the WHO in the global launch. In the top right, this is actually, that is Cassie. This is Carrie. This is her wedding picture, but she was diagnosed with cervical cancer in 2019. And she lives in New Jersey. And then on the far left, this is Corrine. She lives in Boise, Idaho. And she was diagnosed when she was pregnant, actually. And then in the middle is Eve McDavid, who lives in New York City. And she used to be a Google executive. But when she got diagnosed with cervical cancer, she now has poured all of her amazing public speaking and organizational skills into starting this organization to try to improve brachytherapy. They're actually working with scientists to devise this new device that makes brachytherapy, which was designed in the 1950s by men. And if you talk to any women, it's incredibly awful experience. They're trying to re-engineer that device. This is Kim and Elvia that I read about in the corner. This is their picture together. That is in the book. This is Barbara, who is from Zimbabwe, and she was living in Namibia when she was diagnosed. She's the pinnacle story in chapter 13, and she's now started her own, it's called Bold Dialogues. It's a group that tries to help women gain their voice. In the middle is Emily. Emily lives in Iowa. She has suffered severely from radiation enteritis to the point where she's on permanent TPN every night. She gets TPN, and that's the only way she can get enough nutrition to stay alive, because her intestines were forever destroyed. And her post-cancer journey has been unbelievable. And now she went back to school and she has a master's in data science and she works on the Iowa Cervical Cancer Registry. On the right is Jess. She's from Seattle, but now lives in Denver. She's non-binary, and she's a really important voice in the book about how everybody has a cervix and you don't have to be a woman to have a cervix.
Right. Non-binary, we typically use they, them pronouns.
Okay, sorry.
I just thought
I appreciate that. Yeah. Okay. This is Carol on the left. Carol had a pelvic exoneration and she has a colostomy and urostomy, and she has very public and very pleased to have this picture in the book talking about, she's one of the leaders in Survivor, which is a cervical cancer advocacy group in the United States. Upper right is Ri. Ri is from Japan, and if you think about stigma with this disease, her story will make your hair curl about how much stigma she had to endure getting from cervical cancer. And now she's married, which is like a 20-year journey for her. And then the bottom is Natalie. Natalie's from Toronto. She was also diagnosed when she was with cancer when she was pregnant. Tamika Felder on the left is the founder of Survivor, which is a very large organization for cervical cancer advocates. She's a powerhouse. She spoke with Jill Biden last year in January on Cervical Cancer Prevention Month. And to her right is Morgan. Morgan lives in Iowa. Morgan was offered the HPV vaccine when she was 14. It was the first year it was out in the US. And she turned it down because she didn't know enough about it, just like 83% of people turned it down the first year in the US. And 10 years later, she got HPV 16 cervical cancer. So now she's a huge advocate, works for Survivor. In the bottom is Brenda, and Brenda is also a yoga instructor, and she lives in Missouri. I think. This is Kim Hulscher on the left. She's from Europe. She's from Amsterdam. This is Carla. Carla lives in Honduras, and Carla also in Honduras, it's been extremely difficult with stigma to talk about cervical cancer. And she's also very out as an ostomate. She ended up with a colostomy for her treatment. To the right is Denisa. Denisa lives in the Czech Republic, and she was diagnosed and treated when she was 29. And just had the lovely experience of having a surrogate baby because the Czech Republic pays for surrogate pregnancies. So now she has a 6-month-old. Next. And this is Loretta Balos. She is in Southern California, and she was diagnosed quite a few years ago, but she's still a very active advocate. In the middle is Sally Quindo Agalo, and she's from Kenya. That's a picture of her in the Gong Hills. And she is a double advocate of HIV and cervical cancer survivor, and she has had to have a colostomy. So she started her own stoma society in Kenya and raises money to try to help people get bags because it's very hard. And then to the right is Katiana Vijay, who's from the Caribbean. So she's about 3 years out from her treatment. I think that's it.
You know, what's really impressive here is how young these women are.
Yeah.
Because very often we speak of cervical cancer as a disease of the older women, but many of them are really young.
Yeah.
And just a reminder that women in high-income countries, you know, working for Google at that level,
Yeah.
are still remaining vulnerable to cervical cancer.
Yeah. That's such a great point, and I learned so much from this book, but one of them is that your stigmas and stereotypes about cervical cancer, you know, are really, like many of these women were getting screened regularly, and they either had a gap in their screening, or they had a false negative test, and that there was really a very broad base of people with cervical cancer that I tried to highlight.
Yeah, I mean, I think what's remarkable for me is they're getting colostomy, so they're at late stage disease
Or recurrences.
or recurrences, and they were getting screened, but that's the outlier.
Yeah, some of them were getting screened. A lot of them were not. Yeah,
We've been a society where there's access.
yeah. Yes, access, yes and no, because I think one of the things, again, that I talk about in this book a lot is, inequity is everywhere. I mean, clearly, we have better access than in Kenya. But, we have areas in our country like the Rio Grande Valley where 10% of women are screened. We have areas like Alabama where there's one gynecologist for 6 counties, and you would have to pay $50 to get someone to take you to a colposcopy appointment to get a biopsy, and there's only one colposcopist, and who has a sliding scale. And so, do we have access in our country is a question that I ask. Yeah. Another question, yeah.
My personal experience is based in the US, and I just think, first of all, this sounds like an incredible book, and I'm very excited to read it. I was also deeply inspired when I first read Half the Sky, so really appreciate that, and like just the power of storytelling. But do you think that, individual stories like this could help reduce some of the stigma? Specifically, like I said, my experience is based in the US, but I remember when the HPV vaccine came out and I was living in the southeastern part of the US, and the conversation was that young girls should not get this because it would lead them to be promiscuous. And that, like, literally verbatim, that was what was said to me specifically and other people that I went to school with. And now those women are growing up and they're having, babies of their own. And if that is still their first interaction with, the HPV vaccine, how do we change that? And do you think that, like, getting more personal stories out would help with that?
Well, I just spent the last 4 years trying to do that, so I'm hoping it's true. But I think combating stigma is multifocal, right? And I mean, I was just blown away when I was at this moth workshop in India, and also the week before, Nellie and I were together in Costa Rica, and I was talking to people from India who, they still can't talk about HPV. A female gynecologist was booed off of stage trying to address cervical cancer screening with her audience because the audience was so shocked. She was talking about something sexually transmitted and below the belt. So, stigma is huge, it's pervasive, and I think it's layered in various ways. I do hope stories help. I hope a lot of things help. I hope education about just that 80% of adults will have HPV at some point in their life. I hope a story like Morgan's, where she turned down the HPV vaccine because she didn't have enough information. She's from Iowa. What is she hearing about it? And then 10 years later, she has HPV-16 cancer and loses her uterus. And so, it's going to be a long haul. But that's what can we do? We keep doing that. Yeah.
I don't know this statistic, but what percentage of women develop cervical cancer because of HPV versus like a spontaneous cancer?
It depends on who you ask, 96 to 98% is HPV associated. It's actually extremely.
It's a lot higher than I thought.
Yeah.
The statements usually is almost all.
Almost all. So that's why it's almost all preventable. It's
Yeah, thank you so much for this incredible stories. That's totally resonates with me because I work as a gynecological oncologist back home. Yeah, I'm from Kazakhstan. Currently, I work at the University of Washington. But yeah, I have more than 10 years of experience working with women, and that's totally resonates with me. And then thank you so much for writing this because I know that we like around this scientific world, we have a lot of articles, a lot of publications around that, but it doesn't show this stigma, this emotions, this personality behind of it, because we know that's only these numbers and like percentages, but so thank you for that. And then the role of men, that's very important, especially in some countries like patriarchal countries, as my home country. I think a lot of women, they don't go to see a provider because they don't have time and they are not supported by their partners, and then even they are shy to talk about that. So yesterday I was lucky to participate in conversation women on global health. So we talked about menstruation, about stigma around that. In some countries, like we whisper about that. We never speak about that loudly, like in front of our male counterparts. So that's a very important part. Sorry, and then sorry, I mean, I'm talking. I was just taking
No,
notes, so I'm
they're
not
all
like
great.
forgetting anything. And then so I also saw a lot of stories of women who were hiding their diagnosis, who would never tell their even partners, and then if they, because they had fear, if they partners, sometimes they would not even not supporting them, but they would not like turn into other way and just leave them. So that's a very lot of stories around that. Then I am curious. I would like to read the book, and then curious about do you want to to spread out? Do you want to will it be an audiobook in audio format? And then the second question about translation, because in some countries they cannot read in English. So that's my questions.
Well, thank you for all of those. And, I do want to say that writing this book, I had so much help, and I was able to talk to a lot of people globally. And for instance, Nellie gave me a lot of similar stories about, women being cast out when they had cervical cancer. And there are many people that are interviewed in the book, and a lot more that I interviewed that couldn't be included personally, but really helped shape the book. And so I think the idea of men and patriarchy and stigma runs heavily throughout a lot of themes. The idea of translation, Cambridge, the contract I signed it's open to translation, but a country has to, there has to be somebody in the country that wants to ask Cambridge if they can translate it. And I do hope that happens, obviously, because it's a global problem, and it's got global examples in it. It's not something I necessarily have control over, but it is something that could happen, which I hope happens. And then the idea of an audiobook, I don't know about that yet. The book launches in January. And so I'm sure I will be learning a lot. I mean, it's open to an audiobook, and it's listed on the website, like in Cambridge, it says, would you like an audiobook? So maybe they're wanting people to say yes or something. I don't know. But personally, I haven't talked about that yet. It would be lovely to have some of the women read their own stories, actually. Or to do, one of my dreams is to roam around and hand the people who are in it books and do presentations with them. And I'm really excited. There was a woman who gave me the story of her daughter. Her daughter died. Her daughter's in chapter 3. And so she was, the years you write a book where it's kind of dark days and you spend 2 years in a vacuum editing, not knowing if anybody will ever read it or if it'll ever get picked up. And I would tell myself that if this book ever comes out, I want the first person that I talked to about it with it to be Nina, whose daughter Tialita died. And she gave me Tialita's story. And so the book comes out on January 13th, and January 20th, I'm going to Savannah, Georgia, to be with Nina, Tialita's mother, and we're talking to a group of people about cervical cancer. So I think one of the most meaningful parts for me is getting to meet the people whose stories are in the book that initially were on Zoom, and then also hopefully talking about the book with them, because obviously it's so personal.
Can I add also, sorry, so about the stigma around the HPV vaccination. So you were talking about that in the US. I was surprised that the US citizen can also be hesitant to take vaccine, because we were trying to launch it in 2013, 10 years ago, and it failed because of anti-vaxxers and everything. So we're trying to launch this next year, in 10 years later, and still that is more tthan 90% of this disease is caused by HPV. So that's definitely preventable. And this book and all this kind of book, they definitely help to spread out and show this to others the cause and that can be prevented.
Well, I think Nellie probably has personal experience with launching HPV vaccine in Kenya and the stops and starts and the pros and so forth. Yeah.
Yes, I got a text message today on a group, a high school group I'm in, and this woman has a forward message that reads, HPV vaccine is available at this clinic in brackets for girls who have not been sexually active. And that's a message that's been circulated. And then the question the person who sent it said, Nelly, is it safe? These are all college educated women. And the question still stands. It really pained me.
I think that's so interesting because I remember, so I grew up in Seattle. And I remember maybe 5 years ago or so, there was these commercials going on that included both men and women. They were at like, you know, in their 20s, and they were like, the whole point of it was like, did you know that like this disease that I now have could have been prevented by an HPV vaccine? And I remember seeing that everywhere. And I talked to my partner about it because he's actually getting the HPV vaccine like right now. And he's almost 30, and he's like, oh yeah, no, it was just never recommended for me. And I'm like, really? My mom told me I couldn't go to college without it. Like that was your mother. that was the like thing that she was like, you can't go to college without this. It's like,
There was a question.
Thanks so much, first of all, for writing this book. The stories are incredible, and they also resonated with me. And I am from Ethiopia. My sister died of cervical cancer while waiting for radiation. And it is a very important book. But as you know, we know enough about cervical cancer. We have the vaccine, the screening methods, and the treatments, but most people globally do not have access, including some, as you mentioned, in the US as well. As researchers, our role is just to come up with evidence that will help public health implementers to institute different interventions. And from your observation and the lessons you learned from the stories, you have specific recommendations to researchers on how to approach the research what we are been doing globally and locally.
That's such a good question, and I'd certainly be open to anybody's thoughts about that. But one of the things that I've been humbled by researching this book, and I'm actually kind of preparing a grand rounds to talk about, is why don't we use advocates more in our fields? You know, why don't we include advocates when we present to talk about HPV? You know, why don't we use the power of story more? And I think that we've all been trained in how we present academically, how we write academically, et cetera. We try to keep it, you know, about the science and not as personal. I just feel like we are missing out by not using advocates more when we present to ministries of health, or when we try to use the data that is really important and the work that's really important to change policy. Because I don't think it's data alone that really moves policy. So I think we should be working with advocacy groups. Your stories like your sister and the heartbreaking part of that, I mean, those are really important. Yeah. But I mean, that's open for discussion, you know. One of the things that I would hope eventually is that this book finds its way into policy courses, just kind of similar to Half the Sky, which really impacted me. And so I have, you know, reached out to some global health people here. It's a little bit hard because the University of Washington, you can't really promote a book that's a for-profit book by a certain person, as is, you know, there's some ethical lines there that you really don't want to cross. But, and I totally get that. But I also feel like using story or using books like this in policy courses, when we're training all the future people here in their global health department and so forth to think about how do they advocate and present to ministers and so forth. And so I think it would be really interesting to think about how do you use cervical cancer as a case study or the vaccine as a case study or so forth. There's so many case studies that come out of cervical cancer that are really applicable for so many global health courses. And it could be a way to get Story more involved as well as the data.
Thanks so much. That's really good.
Yeah.
You know, one of the things, and thank you really, Linda, for this, and even for bringing us together. One of the chapters in your book is it what is a woman worth? And I always feel like we've never really engaged that as a research question. And I don't think we've really documented the cost of a woman's death, because that's what tells what a woman worth is. And I remember one of my professors saying, for example, for maternal health, that in our parts of the world, pregnancy is just putting yourself a step away from the grave. But that the impact of that in the whole community and family, on children, on, you know, what happens to the whole unit behind, because she dies quietly. She's often, what was Eldora, the woman from
WACh. Yeah, she just
WACh.
cast away and she just dies quietly.
She dies quietly. But what happened to her two children?
Yeah.
Who took them up? What became of their lives?
Yeah. Yeah. And and the generation, so this is gonna be part of my grand rounds, but you know, the generational poverty that comes from when you take a woman out, right? We all know that, but how do you document it? The WHO for the cervical cancer elimination strategy did, oh, thank you, Kathy, I see your message. They documented that for screening in low resource settings, so in 90% of the country, of the world, if you $1 spent on screening brings $3.20 directly back to the economy just in keeping women working. And then if you calculate the amount that's brought in for all the non-paid work, for the childcare, for the caring for the elderly, for the running all the organizations, for everything, it's 26 to 1. So that is the key fact that's in that what is a woman worth? You spend $1 on screening, you get $26 back to your economy. What other public health intervention do we have that has a 26 to 1 ratio? Not that many, you know, and so they have documented it some, but I agree. And then I do know somebody who's doing research up in Vancouver, in Tanzania, who's looking at the generational poverty that happens when you lose somebody to cervical cancer. Really quantify that. Because it is a really good health investment when you have limited dollars and you have to choose how you're going to use those limited dollars.
Linda, we have a question from
Okay.
Donna.
Oh, was it difficult to transition from academic writing to narrative writing? And did you do any preparation to engage in narrative writing? Gosh, it was difficult, extremely difficult. And I think I had an experience 10 years ago where I had a son who was involved in a really severe car wreck, a brain trauma. And he was, and I started writing a Caring Bridge blog to keep people up to date all around about his care. And that was probably my first experience in narrative writing. And I found it really a powerful synthesizing tool for me. And then I ended up getting a lot of positive feedback about the blog and the stories in it. And I think that was the first time I really started thinking about the idea of storytelling and narrative writing was through that own personal experience with my son's really severe car wreck. And then when I was getting ready to write this book, I remember thinking, oh, how hard can it be? I was so naive. I took some online courses in narrative writing and how to write a book. And then I also hired a book coach. And for me, the book coach hiring was for efficiency because I had a year off of work, but then I had to come back and keep seeing patients. So I really couldn't be in these big writing groups where you like critique each other's writings and so forth. I just didn't have the time for that. And then the nice thing about this writing coach is that she knew nothing about HPV. And so she was not medical. And so if I said something, she's like, out. out, out, use the word stakeholder, that's jargon, out, 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 And so I think, and frankly, some of these chapters have 20 revisions, I kid you not. And so, yeah, it's not an easy transition. Okay,
Ms. Harrington, question, chat.
what do you think can be done about the stigma? I think we were just talking about that. I'd be open to your ideas, Liz, and anybody's ideas. I think we have to keep talking about it and offer education and offer story and, oh my gosh, but the courage, like, what do you study in India who's a provider trying to give education and gets booed off a stage? I mean, the courage that it takes. When you can't even have advocacy groups, India doesn't have a cervical cancer advocacy group because they don't live. They don't have survivors. So I think we just keep working with all we have, and the survivor network is really helpful to reach out to other survivors too, to encourage them, I think, to have voice. I think in a way that I, as a white medical provider, cannot. But, somebody in Kenya who's been, I just met a stage 4 survivor who was kicked out by her husband and her family and is kind of impoverished and working really hard, but still trying to talk about cervical cancer. Those are the people that I think make a really big difference in stigma and in encouraging other people. Thank you for your positive feedback. So,
I think it was a little bit late, but I didn't hear the reason why you wanted to get into this topic. Was there any specific reason?
I think the bottom line is I get tired of watching women die terrible deaths from a preventable cancer. And I just got angry. I think anger fuels a lot of things. And I just had too many patients that I was in a room with that I had to tell that this is what was, I'm not an oncologist, I'm a general gynecologist, but I work at Harborview. We see a lot of people who've never been insured, who's never been screened. We see at least one advanced cervical cancer a month. And we just had a 3B come in last week. And so I'm just tired of it. Yeah. Thank you. Yeah.
I think your next book should be about the power of female anger.
That's not a bad idea, but I'm not sure there's a next book.
That's fair, that's fair.
Not at this point, oh my goodness. Yeah. I think the other thing I learned was writing a book was, for me, an act of privilege. I hired a book coach and I had the ability to make Zoom calls, and I had all these connections with people that I'd done global health work with, and I could never have done this book without so many people and so much help. And that was really humbling too. And then going through the finding an agent and finding a publisher, oh my goodness. So anyway, that was something.
How do we order them? How do we get hold of
Oh,
them?
well, if you want, there's some cards. You can pre-order it from Amazon, from Cambridge. Cambridge just put out a trailer on their website, which is pretty fun. And then I also I have a launch coming. If anybody is going to be in Seattle, January 13th, I brought invitations to the launch and online. Yeah, and then I also have some information about how this could be, in my vision of how this could be in a public health course, if anybody wants this. Anyway, I'll just pass this around, and if you want one, take one, but feel free, no obligation. I have to say that Cambridge is doing what they're doing, and I'm really appreciative for them, but the book is only in hardback the first year, so it's $25. I never paid $25 for a book. And in the second year, it's going to be in hardback, in softback. And it'll be $12. But yeah, so anyway.
Linda, do you have digital copies of these that I could share?
I do. Yeah.
Great. I think the online participants might like a copy.
Yes.
Yeah.
Yeah.
The ICRC.
And also, I think that if people certainly something I'm open to if people like, I'm reading in Zimbabwe or iTech Namibia. Like, I'm very open to asking Cambridge of, hey, can we get bulk of deals and get this cheaper? Or, kind of, how do we do this? I mean, $25 it's a lot. And so that's why I'm not saying go buy this book, but,
Go buy it,
but the color photos are killer. I'm so excited about that.
Any final questions for Linda?
What's the efficacy of like the HPV vaccine?
So the efficacy of the HPV vaccine, there's two types. There's the first type had two types in it, HPV 16 and 18, which cause 70% of cervical cancer. And so if you get those before you are exposed to the virus, the efficacy is 98%. It's an amazing vaccine against those types. And then the newer HPV vaccine protects against 90% of cervical cancer types. But even if you get it after you're sexually active, Nellie's question, and you've been exposed to one HPV type even, you won't have likely been exposed to all the others. But the vaccine itself, to prevent the HPV types that are in the vaccine, is 98%, 99% effective. There's just no vaccine. I mean, look at the flu vaccine. We're excited when it's 50% effective. It's just an amazing vaccine.
You mentioned that you get false negatives, at times, and we can't know there's HPV and person doesn't go back for screening. Is there more reliable testing?
Well, the pap smear had a lot higher false negative rate than the HPV test.
Okay.
And so that was the reason too why pap smears have to be repeated more often than HPV tests, because they have more false negatives. And the cancers that they missed the most were the ones that are higher up in the endocervical canal. And so that's the nice thing about HPV-based screening, is it picks those up more easily. And WHO has recommended to try to transition to HPV-based screening. It's just that the cost of it right now and the technical challenges is, we still need the holy grail. You need to be able to pee on a stick and tell if you have HPV. Just like with COVID, where you swab. I mean, that's the holy grail. That's what I think of the holy grail. We need a cheap, reliable HPV test, point of care. And people are working hard on that. And we do have HPV testing, but HPV testing is better than pap smear.
There's a question in the chat from Sandy asking that many of the stories are very raw and personal. What are some ways you approached collecting the stories that would sometimes require people to relive those experiences when retelling them?
Yeah, and that's I was very humble about that, especially asking this mom to talk about her daughter's death to a perfect stranger. So there was a process where I reached out to people both online and through a website, and people would contact me if they wanted to give their story. So, and that was a kind of a consent form. So I would never approach someone to give me a story if they didn't approach me first. And then, but when you get these people that are in advocacy groups, a lot of them have been telling their stories to anyone who will listen. And I am so impressed at what other people will do to keep others from getting cervical cancer. I mean, they will tell their story to anybody if it will help prevent somebody from getting cervical cancer.
Thank you so much,
Oh, thank
Linda,
you.
for being here today.
Allowing me this.
Thanks to everybody who attended
Yes,
online.
thank you, online.
Thanks.